presenting a case of 65-year-old male who underwent a complicated SICS surgery, and the ACIOL was placed, which is, we can see that one haptic is in the sulcus, whereas the other haptic was touching the cornea in the supranasal quadrant, and it is accompanied with corneal decompensation, edema, and corneal scarring. So a side port was made, and the previous SICS tunnel was reopened using crescent and keratome blade. After doing that, a dialer is inserted through the side port to disengage the haptic and corneal adhesions. Another side port is made at around 10 o'clock to further disengage the IOL haptic, and using the main tunnel, the AC IOL is explanted. Now, after explantation of the AC IOL, viscoelastic is injected into the AC and the corneoscleral tunnel is sutured, and minimal limited anterior vitrectomy was done. And using the same vitrectomy cannula, a small peripheral iridotomy was made at 5 o'clock. Now, two side ports are made at 9 o'clock and 3 o'clock position using the stab incisions, which will eventually be used for enclavation of the iris claw lens. After confirming the convex side up of the lens, the iris claw lens is implanted into the anterior chamber with horizontal position of the claws of the lens. With the amount of scarring in the nasal region, it is quite evident that enclavation of the lens is going to be difficult in this part. Now we can see that the iris claw lens holding forceps is used to grasp the lens, keeping in mind that the position of the horizontal edge of the forceps should correspond with the level of the notch of the claws of the haptics, and the hydrocannula is used for smooth enclavation of the lens at the temporal site. Now coming to the difficult part of enclaving the lens on the nasal side. After re-grasping the lens in the position as mentioned before, we can blindly enclave the lens through the opaque area, keeping in mind the position of the horizontal edges of the forceps, and then we can check the stability of the lens. And finally, the main port is sutured and the side ports are hydrated. Now coming to our second case, which is a case of traumatic subluxation of more than 180 degrees with secondary glaucoma with iris atrophy in the inferior quadrant and a fleshy nasal pterygium. At first, the nasal pterygium is excised to get better visibility behind the mass. Now this case was equally challenging due to multiple factors pertaining to the case. Due to such large subluxation of the lens, an ICC with iris claw lens was planned for the patient. The second challenge in the case was development of atonic atrophic iris, which developed due to traumatic glaucoma and a high intraocular pressure. This would lead to difficulty in constructing the pupil before placing the intraocular lens. A clear corneal incision is made with a minimal corneal tunnel, and AC is entered using a keratome blade, and ICC is performed, and after closing the incision with 10-0 nylon, anterior vitrectomy is done. After performing the vitrectomy and injecting pylo, we can see a vertically oval pupil. The iris claw lens is again checked for the convexity and it is placed into the anterior chamber. The third complexity pertaining to this case is the opacity and haziness at the nasal side of the cornea, which will hamper the visibility during the inclination of the iris claw lens. The lens is implanted into the anterior chamber, placing it in the horizontal position, and again while holding the lens with the iris claw lens holding forceps, we'll again be sure of the position of the horizontal edge of the forceps, which should be corresponding with the level of the notch of the iris claw lens, and one smooth movement ensures the inclination of the lens using the hydrocannula. The horizontal edge of the forceps gives a rough idea about the position of the notch of the claws behind the iris, and we can smoothly use an enclaver or a hydrocannula to enclave it in the direct line of the horizontal edge of the forceps. The stability of the lens is finally checked with the help of a dialer, and we could assess the instability of the lens. Hence, a second trial at enclavation was given, which was eventually successful. After being completely sure of the stability of the lens and enclavation, the main port was sutured, and limited vitrectomy was used to remove the viscoelastics, and the ports were hydrated and the eye was finally closed.